Good afternoon, and welcome to the FEMA Region 2 Individual and Community Preparedness Webinar Series. My name is Allison Albright, and I'm the Regional Preparedness Liaison for FEMA Region 2. I'm going to provide a few technical considerations before we begin. Today's proceedings are being recorded and captioned. The archived event will be available on the FEMA website in the coming weeks. You should hear audio through your computer speakers, so please ensure your volume is turned up so you may hear the proceedings accordingly. In the top right corner, we ask if you'd like to receive news and updates from Region 2. If so, please enter your email address and I'll be sure to add you to the distribution list. We will have a question and answer session after the presentation concludes. You'll see a Q&A pod in the lower right-hand corner. Please feel free to submit your questions about the subject matter there, and time permitting, we'll do our best to answer them. Finally, the PowerPoint presentation from today will be available for you to download in the file share pod as a PDF. You can click on the file and download it using the download button. With that, I'd like to turn it over to the Region 2 Community Preparedness Officer to introduce our speaker and today's proceedings.
Good afternoon, everyone. I'm Debbie Casa, the Community Preparedness Officer for FEMA Region 2. On behalf of our team working to strengthen preparedness across New York, New Jersey, Puerto Rico, and the Virgin Islands, I'm so happy to welcome you to our webinar series. The FEMA's 4-year strategic plan, the agency's goal 1 is to build a culture of preparedness. The Region 2 Individual and Community Preparedness Program is focused on preparing individuals and communities for disasters by providing useful information and training, inspiring people to take action and be ready for any emergency. As part of that goal, we're pleased to be hosting today's webinar on the emotional impacts of COVID-19 control measures such as quarantine and lockdowns on older adults. In this webinar, you will learn strategies on how to support the emotional well-being of senior citizens who are affected by COVID-19 prevention measures and the changing circumstances of the pandemic. Our guest speaker today is John Ruyan from Americares. He is a psychologist who holds a master's degree in counseling psychology from Neurocognitive University, Colorado, with a concentration in transpersonal wilderness therapy. He currently works for Americares as a member of the mental health and psychosocial support team, where he has served responding to emergencies like the Puerto Rico earthquakes in January earlier this year, and now to the COVID-19 pandemic. In addition, John works with Fundación Kinesis, offering personal development workshops in the island's public schools. Mr. Ruyan also served as a member of the board of directors of Fundación Dr. Johnny Ruyan. John, I'd like to hand the mic over to you.
Thank you very much, and good afternoon to everybody who's joining us today. I'm pleased to be granted this opportunity and to share this information, which is so valuable and so necessary to assist and aid our elderly in these trying times. The elderly and the emotional impact of disease control measures is the name of this presentation, and as I mentioned, we're going to be offering not only knowledge and facts around what our elderly might be experiencing, but also what can we do about it? How can we be of aid, whether it be a family member, whether it be someone that we attend in any kind of health service, as a health service provider or any type of healthcare facility. So here we go. I'd like to briefly mention beforehand a bit about Americares, which is a non-governmental organization which for over 40 years has offered humanitarian aid and emergency medical assistance to help people worldwide enduring poverty and or disasters without distinction of race, creed, or politics. Our mission is to save lives and improve the health of those affected by poverty and or disaster so that they may reach their highest potential. And obviously, currently we are with all cylinders attending this current crisis, which is affecting nations worldwide. So in order to begin, let's take a quick look at Don Julio. Okay, and anyone can imagine Don Julio as maybe someone that you might know, or even as your own self. And let's study Don Julio's case, and maybe we can use this as a reference throughout the rest of the webinar. Don Julio, an 87-year-old adult and resident of Oasis of Love Center, is in the initial stages of Alzheimer's. Before an emergency was declared in Puerto Rico due to COVID-19, Don Julio loved playing dominoes with his companions in the game room and sharing with his children and grandchildren during their constant visits to the center. His eldest son recently received a call from the nursing team. Quote, Don Julio has been strange lately. He's sad all the time. He has become a bit violent with the staff. He seems disoriented, and he's forgetting things more often. Sometimes he doesn't even want to be bathed or wash his hands during the day, and much less use a mask. We've noticed that all of this started ever since you have all been unable to come visit him, and since he's spending more and more time alone in his room. So I'd ask you to consider, do you know anybody like Don Julio? Is there anybody that you work with or any family member who resembles this case? And I'd like to also take advantage of this moment to invite everybody to use the chat box. You know, we obviously there's a sea between us right now. I'm here in Puerto Rico, you know, where everything is virtual nowadays with COVID. Conference rooms are more and more virtual, workshops. So the chat box becomes ever more crucial to help us try to make this as much as possible, resemble an in-person conference. So throughout the webinar, I'll be asking questions, and everyone can take a moment and respond in the chat box, and we'll be attentive to your responses. So the first question I'd like to ask, and I invite you all to use the chat box, is what would you maybe say to Don Julio? In which ways would you think that he could use some assistance? And what ways do you think you could assist or help Don Julio given this scenario? We'll take a moment to just check out the different responses that people are answering in the chat box. You see here phone calls. You see people who have similar situations in their family. Maybe it's a mother-in-law. Window visits, FaceTime, family visiting. We see a common theme in all of your responses is very spot on, is to have some outreach, to have some social contact and connection. You know, to defy that sense of isolation. You know, something that a big slogan here in Puerto Rico, I'm sure it is in other states, is physical distancing does not equate social distancing, right? We can't be close contact physically, but especially with all the technology we have today, we can always maintain that social connection. Okay, so thank you so much for all of your responses. I hope you take a minute to check out what other folks are responding. As far as I'm seeing, very important, great suggestions. And let's continue. We'll see a bit more in detail how we could work with someone like Don Julio. So as you can probably already tell, the main objectives of this webinar are the following. In first place, to understand the incidence and prevalence of mental health disorders in the elderly, to analyze the main challenges of the elder community in relation to COVID-19, identify the impact and possible effects of infection, prevention, and control measures on the elderly in this context of COVID-19. We know that this is the most vulnerable population in this worldwide pandemic. And so there's not only a threat to their physical safety, but obviously to their social, emotional well-being. So therefore, we want to recognize and identify emotional support strategies for the elderly in the face of these security measures, changes, and circumstances related to COVID-19. And it's important to mention that experiencing a certain level of anxiety is not only normal, but necessary in order to not lower our guard considering these established safety measures. Let's imagine for a second that you or I would not feel any stress or anxiety at all related to the COVID-19 pandemic. That would lead us to act carelessly and to not only put ourselves in risk of contagion, but also of everyone around us. So that would be extremely dangerous. So it's important to have some level of stress, a healthy dose of anxiety, of stress, in order to take action and to take the necessary precautions. However, as we'll see later, obviously this can extend a certain threshold and become paralyzing. It can become, in some ways, disturbing. So we want to be able to also learn how to lessen those emotions, anxiety, that stress, that fear of death, and manage them so as to find that kind of ideal midpoint that in psychology is termed eustress. So it's important to understand, what specifically the elderly might be feeling, and obviously we can, identify that there's obviously a need for affection, a need for contact, a need for help. Yet, with this paradoxical fear of contagion and death, so I need you, but being close to you might result in my sickness and even death. So this is a very important paradox to understand, that when we need to be most distant from the elderly to protect them, at the same time as when we need to be closest socially to help them not feel alone and not have to endure those difficult emotions. So some more important considerations with regards to this is that there are two large groups of older adults, right? First, we have those that have an impaired cognitive function or a neurocognitive disorder, and those who do not have this kind of condition. They have normal cognitive functions. And this is a very important factor that we're going to be looking at a lot during this webinar, and the special considerations for those who have a condition as that or not. Both groups are at higher risk of mortality due to COVID-19, although those who have intellectual deficits, and especially those with Alzheimer's disease, are probably the most susceptible. This last disease, Alzheimer's, corresponds to approximately 70% of those who have an intellectual impairment. So of those who have an intellectual impairment, around 70% of the cases are Alzheimer's.
John, can you please speak a little bit louder?
Yes, pardon. How's this? Is this better?
Yes, thank you.
Okay. So first, let's begin talking about the elderly folks without cognitive impairment. Physical and social isolation can trigger confusion in these folks, even in people obviously without a cognitive impairment. This is normal. This would be similar to the institutionalization that occurs in many normal elderly folks upon admission to a home. It is produced by the change of place, the modifications of routines, lack of light, and the absence of social stimulation so commonly endured in this situation. So you can only imagine, if this is the type of reaction that can be expected under normal circumstances, imagine how much it is exacerbated or heightened by the security measures and the infection control measures due to the COVID-19. So these are obviously considerations that we need to have in the forefront. And to notice that it can affect elderly with or without conditions. Now, those who do have cognitive impairment are those with the highest risk, as many secondary problems are added to the infection of the COVID-19 virus. Given their cognitive characteristics, the changes in the rules and routines which accompany infection control measures can strongly affect them. Okay? So let's take into account that the mental health of the elderly in the face of COVID-19 and infection control measures, as we have been speaking about until now, and let's dive into the numbers real quick. Neurocognitive disorders represent 6% of the total disabilities of the elderly population. Approximately 20% of adults over the age of 60 suffer from a mental health disorder. Dementia and depression are the most common neuropsychiatric disorder in this age group. couple more numbers, 47.5 million people in the world have neurocognitive disorders. 7.7 million new cases arise per year, and it is projected to increase to 75.6 million in 2030 and as much as 135.5 million in 2050. So all this goes to show that this is normal, right? And we can expect this. And it's important for us to be somewhat, detectives and to be sensible and to be alert, to look for the signs of this, to expect it, and to treat our elderly as if they had one. To give that benefit of the doubt and to offer best practice, the best care, considering how prevalent these conditions are. Let's talk a little bit about neurocognitive disorders. We're not going to dive into analyzing, dissecting the DSM, but I want to give a brief overview of kind of the map, right? The lay of the land of the main types of neurocognitive disorders. And then after that, we'll go into, well, what do we do to help? How can we assist the elderly with or without neurocognitive disorders given these circumstances? If anyone has any more a more detailed question about these disorders, at the end we'll have 15 minutes for Q&A, and we have some extra slides with more details if anyone would like to ask something more precise. But for now, we're going to do a brief overview. Okay. NCDs, or neurocognitive disorders, are diseases that affect higher brain functions as a consequence of neuronal damage, such as memory, thinking, orientation, understanding, calculation, learning capacity, language, and judgment. As a result of this, the person's autonomy in their daily life, in their daily activities, is affected significantly. Neurocognitive disorders were previously known as dementia. This is important. So as to not get confused, when we refer to neurocognitive disorders, it refers to everything that was once known as dementia. That is now all encompassed under this term, which we'll have abbreviated in the rest of this presentation as NCD, short for neurocognitive disorders. So they're considered neurocognitive disorders, those that typically affect people over 60 years of age. Cognitive decline has not been present since birth or early in life because it is onset later in life. That is part of the definition. And they represent a deterioration in the previous level of function. So there's an aspect of novelty to it. It's something that arises with age. And as we saw, it is quite normal. So let's talk about some of the domains of our neurocognitive functions, which would be the domains that are affected by these conditions. So we're talking about our ability or our domain of complex attention, processing speed, able to focus on something, have sustained selective attention, multitasking, etc. There's executive function. Everything has to do with planning, decision-making, working memory, inhibition, mental flexibility, feedback, error correction, and of course, learning and memory. Aside from these, we have another 3 domains: language, perceptual motor, visuospatial coordination, and social cognition. And the main types of neurocognitive disorders, we have delirium, and then of all the other disorders, they can always be classified as either minor or major, and later we could talk a little bit more about what distinguishes a neurocognitive disorder from being minor as opposed to major. It usually has to do with basically the severity of symptoms and how much does it affect the person's daily functioning. Can they carry out their daily activities as usual, or is it significantly impaired? These are the main criteria to distinguish between major and minor. Okay, so let's jump into depression for just a second. Depression in the elderly tends to manifest itself more through somatic complaints. So you'll notice this is kind of similar to when we observe children and babies, where the linguistic aspect of presenting or a complaint or a problem is a little bit more absent, and we have to pick up cues in how they play and how they gesture and what their body is presenting. We find a little bit of the same dynamic with the elderly population. It might be more difficult to express, but we can pick up the signs and how it's manifesting through somatic complaints. And their body will keep the score. Their body will reveal what is going on. So oftentimes, depressed older adults tend to feel tired, have trouble sleeping, or become irritable. Older patients with depression are at higher risk of suicide. So it's very important in whichever protocol, whichever institution or agency that you're working in, that the staff be on a very clear page on what are the signs of suicidal behavior, suicidal ideation. Is there any system to kind of screen and check in with the participants, clients, members, to make sure that we're looking out for their signs and taking the right course of action. And there should be a protocol of how do we respond in this institution to when we see these flags. This is paramount. Attention problems or confusion caused by depression could be mistaken for Alzheimer's or other brain disorders. Okay, so it's important to have clinicians in the team who can discern between one and the other. And today, you all will walk away with at least the minimum to understand some of those main differences. So to identify it as depression, these are the main symptoms that would be present for over a period of 2 weeks at least, sustained. Okay, so we're talking about a depressed mood most of the day, almost every day. A marked loss of interest in all or nearly all journal activities. And as I go through these, maybe think back to Don Julio. Did Don Julio present any of these symptoms? Or is maybe somebody that Don Julio reminded you of? Do you notice any of these signs and symptoms in that person? That way we can start applying this to real life. So aside from that lack of interest in normal daily activities, there can be a significant weight loss or an increase or loss of appetite almost every day. So drastic changes in eating behaviors and habits. Same with sleep habits, insomnia or hypersomnia almost every day throughout 2 weeks. Or psychomotor agitation or retardation, either or, almost every day, sustained throughout 2 weeks. So notice how it's a pretty significant period of time to be experiencing these things on the daily for 2 weeks is something that is definitely going to stand out. So it's important to know that this is what is required to actually, for someone's case, that should be classified as depression per se. Fatigue or loss of energy, feelings of worthlessness or excessive guilt, decreased ability to think, concentrate, or make decisions, and recurring thoughts related to death, suicidal ideation without a specific plan or attempts. And all of this, without a doubt, deeply affects the functionality of the individual, their ability to carry out day-to-day activities. And sometimes just that alone is kind of a signpost and an indicator that there's maybe something more serious going on. Maybe you notice how something that they used to always do, play, I don't know, maybe they used to play bridge at a specific hour with a certain group of friends, or they used to always go wash their hands at this time of day, and all of a sudden they're not doing these activities. Changes as subtle as those could actually be indicators and an invitation to look a little deeper and maybe identify some other criteria that you just mentioned. The depression in the elderly, as I said, we need to watch for these early signs, treat any conditions that may be causing the symptoms, and if you are a medical personnel, stop any medication that may be making the symptoms worse. Right? Just like the Hippocratic dictum, before anything, do no harm. We want to make sure that we're, removing the hand from the fire before anything. We want to make sure that we are taking away any medications that might be making this depression symptoms worse. And to be open to question that, right? To to be attentive and ask ourselves, wait, what medications are they taking? What effects might this one have? How about this other one? Consult with the clinical team and be assertive and make decisions because it's up to us. Okay, so as I said earlier, it's important to be able to distinguish between, what is a neurocognitive disorder versus a depression. These are not the same thing. So depression may include symptoms of dementia, that's the outdated term. It may include symptoms of neurocognitive disorders without necessarily being one. So they can be easy to confuse, and that's what is termed pseudo dementia, or cognitive impairment associated with depression. But it's important to be able to distinguish the two. As I said, we're not going to go too deep into the world of diagnostic criteria and the classification of these disorders, but I just want to sort of paint a picture or lay quickly a aerial view of what the terrain is. But let's focus now on what are all these preventive measures of infection control that are only adding to the difficulty of those who are at risk of these types of conditions. Okay, and with this excellent graph from CDC, we can see how there is just an incredible, overwhelming amount, an overwhelming percentage of infections and death due to COVID that pertain to folks over 65 years old. And as we see over here, we have hospitalization on top, death on the bottom, and once we get up to 65 years old to 74 years old, we see in deaths 90 times higher than the comparison group, which is 18 to 29 years old. We see a 90-fold increase. And the older we go, it just doubles, and 85 plus, we have up to 630 times higher death rate. Okay, so in summary, 8 out of 10 deaths reported in the United States from COVID were adults 65 years of age or older. Okay, and just this information itself is enough to really trigger someone of older age, to make them feel very vulnerable and helpless. So, as I said earlier, it's not only the physical threat, but there is a ginormous emotional threat of knowing that this could be something very dangerous for them. And especially if they're at higher risk with a neurocognitive disorder. Now, those who have a higher risk of becoming seriously ill may have, just to kind of take a little trip into the minds and try to be empathic and understand what they might be concerned about. Well, the studies have revealed and experiences throughout this adventure through the pandemic is that they have a very large concern about how to protect themselves, right? What are the right measures? Is staying indoors the most important thing? Is it washing the hands? Is it airborne? Is it more this? Is it more that? So confusion and concern about what are the right measures to take. Aside from that, concern about possible interruption of medical or community services. Talking about lifelines, vital services that in their minds might be interrupted or at risk of being vanished or not available when I need it. Okay, so all of this, you can only imagine the amount of anxiety and dread that it can provoke. Obviously, feelings of social isolation. We are social beings. We come into this world always in contact with humans, and we're now going into almost a year of social distancing. And I think it's important to remember that at that stage of life, what you're wanting most is to connect with your loved ones before it's time to part. And I've heard of cases here in Puerto Rico in my family or surrounding friends where it's like it's not worth it. Like I have elderly folks in my family who will just wanna just give me a hug. I'm like, oh, forget about it. Like I need a hug. That's what I need. And we need to really take a lot of care and do what's right and find a way to offer that social support without putting them at risk physically. But it just goes to show, how big that basic human need of social contact is, and we need to be very conscientious and attentive to attending that. Okay, so in addition, we're talking about guilt, right? They might be feeling guilt if their loved ones have to help them with their daily life activities, or concern about not getting essential items such as food and other personal care items. So there's a plethora of reasons for dread, for stress, for anxiety. The list only continues. So even higher levels of distress, what I mentioned earlier, this is kind of the basic scenario for almost anybody above 65 during these times. But then we could have higher levels of distress if that person had a mental health problem such as depression prior to the pandemic, right? And, we're talking about interruption of services, the continuity of them. That's one factor among others that can make this a really challenging aspect. In addition, if they live in low-income households or have language barriers, we know how difficult this is in the United States to find interpreters, to find translation, to find services available to me in my language. So we need to be very aware of this and be able to aid and connect with the services and the language that person needs. They have several chronic conditions and need medical attention. And lastly, if they suffer stigma because of their age, their race, or ethnic group, or disability, or because they're perceived as possible agents of COVID-19 infection. And we offer another presentation specifically on stigma and discrimination amid the COVID-19 pandemic, where among other profiles, but the United States has been a trend of blaming those who come from China, and almost kind of this generalization as if anybody who comes from Asia or even looks Asian is more likely to carry the virus and this and that. And there's all these forms of discrimination, which in some cases have even appeared in an institutional fashion. So that cannot happen, and we need to be aware of that. And in this particular case, looking at how that might manifest in the elderly population, considering that age in and of itself could be one of those factors that lead to stigma and discrimination. One second. Okay, so what are some of the signs? We mentioned earlier one of the signs for depression, for example, might be changes in habits or usual routines. Well, let's talk a little bit more about some other signs that could reveal that loved one, that client, or any person from the elderly population, a sign that they might be undergoing a lot of stress or emotional difficulty given all these measures and infection control. One, feeling of numbness, disbelief, anxiety, or fear. We can also see changes in appetite, energy, and activity levels, difficulty focusing, difficulty sleeping, nightmares and disturbing thoughts and images, or physical reactions, as we mentioned earlier, such as headaches, body aches, stomach problems, and skin rashes, right? All these psychosomatic manifestations that we need to also pay attention to, and always be open to realizing that it might not be solely a physical ailment, right? That this can actually be something that is indicative of a more social-emotional issue. It's always good to have that lens. Aside from this, symptoms associated with depression that we mentioned earlier, feeling disoriented and as if losing track of time, desire or intention to harm self or others, question the meaning of their existence, right? And especially in this circumstance where no one's free from this risk of contagion and possible death. So right, it can provoke those kind of existentialist kind of considerations, and anger or a bad mood. Spiritual beliefs growing stronger or weaker. We see this very commonly in times of great crisis. We tend to either renounce faith and to feel betrayed in a way, or to hang on and connect more than ever with our faith. So it's also important to know that these are all very normal reactions. Aside from this, aggression towards others, conflict, maybe where there wasn't conflict before, isolation to a degree that wasn't usual, the worsening of chronic health conditions, or an increased consumption of alcohol, tobacco, or other drugs. Okay, so as I said, it's only natural, right, to feel stress, anxiety, pain, and concern during and after a pandemic. We want to make sure that we have some degree of stress to respond appropriately, but not too much where it's actually sickening us. So, everyone reacts differently into different degrees, and everyone has their sweet spot, right? Everyone has that midpoint that's ideal for them, and it's important to understand, right, that it's not going to look the same for everybody. It's always important to maintain the awareness when exchanging with the elderly who are going through this, that, these feelings are normal, and they will change over time. Right? The way you feel right now you're not going to feel like this forever. But it's important to acknowledge how one feels, right, as a care provider, to offer that space or that container where they're allowed to feel what they feel, they're allowed to express how they feel. That is one of the greatest, most important things that we can offer our elderly folks who need that contact, who need maybe an escape valve to just express and be allowed to feel how they feel. Take care of their emotional health during an emergency. This will help, right, this kind of applies to everybody, but of course the elderly, it's important to take care of their health in an emergency, and this will help them to think clearly and to react appropriately to attend to the need to protect yourself and your family. And this obviously goes for us as well. As healthcare providers, we need to be with our own 2 feet steady on the ground to be able to assist others, right? That's why self-care is so important in any emergency, because it helps us cope not only in the short, but in the long term. Because sometimes we can feel like superheroes with unending strength and energy and willingness and love and care, but that does take a toll. And I've seen some pretty drastic cases where once, at the other end, coming out on the other end, there's really kind of a collapse that's very concerning. So it's important to take those little breaks or whatever it is they need to do to keep yourself okay during, not only after it's all said and done. Okay, so some useful recommendations when attending our elderly folks who are going through all these things that we've mentioned up till now. One thing we can do is to subtly question the negative thoughts that they might have. And you don't have to be a psychologist, a counselor, you don't have to go into cognitive behavioral therapy, but the essence of that is simply what we can all do, and it's what we usually do as friends in normal conversations, right? Maybe help coach and guide them to consider, why do you think you're not going to be able to do this? Well, help them talk it out and talk through it, and help them find their own conclusions, kind of like the Socratic method, right? What happened when you tried? Kind of a little bit probing, a little bit kind of pushing, but mostly just guiding and accompanying in that reflection with them. How do you think we could change it? Okay, so a lot of times you may need to be a little bit more directive. A lot of folks need that, someone to kind of guide and coach them. So it's important for us to acknowledge that is part of our role, right, in assisting the elderly. And all this right, with the intention of generating positive emotions, and to remind them of past events that brought them satisfaction. Important to engage in age-appropriate recreational activities that are enjoyable. Obviously, this is a little bit limited with the COVID restrictions. Maybe dominoes isn't an option as it used to be because you can't be touching the same dominoes. But that's where technology can really come in handy, and we can find ways to substitute normal activities in a more virtual format, or simply just do new things that we've never done before. Hey, maybe instead of dominoes, let's go sit outside on a bench and look at the clouds go by and the falling leaves and chat. Okay, so it's important to get creative in these times. I'm sure that's something that I don't need to say. We've all found our little secrets. Aside from this, encourage physical activity as much as possible, right? Always being aware of physical limitations, but trying to go outside the box and trying to find ways to get those endorphins flowing, the serotonin flowing, right? We know all the benefits of physical activity in our physical body, but not everyone knows that physical activity plays a crucial role in your mental health on a neurobiological level, because our brain secretes endorphins, which is the naturally occurring endogenous form of morphine, which is a painkiller and also produces pleasure. Well, our brain has endorphin, and we naturally secrete it when we do exercise without any side effects, and it helps us get that kind of runner's high, as it's known. Aside from this, our brain secretes serotonin, which is the main component or the mechanism of action in antidepressants, SSRIs, selective serotonin reuptake inhibitors. The best way to deal with depression is to increase the flow of serotonin in our brains, and that is exactly what exercise does for us without any side effects. In addition, it helps us sleep better at night. We all know that sleeping is crucial to our emotional well-being as well. So, very important to maintain physical activity, and this means maybe just after eating, a 10-minute walk. And that 10-minute walk after eating will help you digest and assimilate all the nutrients better, and blood flow, oxygen, and obviously these neurochemicals in our brain which promote happiness. Social interactions. Obviously, when we mentioned Don Julio, everyone in the chat box, what I saw was mainly, phone calls, opening windows of communication, FaceTime, and that is definitely a lifeline for our elderly in these times. We need to promote social interactions. We need to reach out maybe more than usual, check in, and maybe get some more people online, use Teams, use Zoom, use WhatsApp chat, and get some more faces in there and feel like it's a family gathering, because those gatherings aren't happening. And especially if elderly folks are in a home and the visits are now limited, we really need to give the extra mile to help these folks feel that company. And as we expressed in another workshop, it's important to also acknowledge that stress and the kind of feelings that can arise from feeling isolated as an elder only weaken and decrease the immune function in their body. So it actually makes these folks more vulnerable and susceptible to taking on the virus. So that's just another reason why we need to really offer that emotional company and support. Aside from this, to promote the feeling of usefulness, right? To have some weekly task or something that we're all counting on you, and we know that you're going to do this, and we celebrate your achievements, and to feel that usefulness, that purpose. Maybe it's creating gifts for their nephews, their grandchildren. It can be anything, but to always keep that sense of purpose and usefulness intact, and to respect individual preferences. Right? To always honor their dignity in that sense. As we said earlier, it's definitely paramount and crucial to listen to them with patience and empathy. And before trying to jump to redirecting the way they think, which is also useful, as we said earlier, but first and foremost, we want to connect before we try to correct, right? Connect, then correct. It's like trying to send an email when you never establish your Wi-Fi connection. It's not going to go through. So same with anybody that we're trying to assist and aid. We want to make sure that first they feel felt, they feel heard, they feel seen by you. And after you establish those 4 bars of connection with them, then you can come in and maybe bring some of the more redirection, coaching, guiding, and anything related to kind of the correction. But connect, then correct. And that's, includes, right, not criticizing the feelings that they express, but offer hope, offer that empathy and that validation. Aside from this, promoting good nutrition, right? We are what we eat. And our brain, just like all the other organs in our body, it's composed of the quality of the food that we intake on the daily. So crucial to promote a good nutrition, as a lack of that can only make depression symptoms worse. And not only to really want to communicate more with these folks, but to actually make a concrete plan. I just challenge everybody to find a way to really make it a habit and to make it something that they can rely on. Because not only is it useful to have the conversation with loved ones in the moment that they're having it, but if they can know 2, 3, 4, 5 days, before having that contact, that if they can rely and know that that's coming, that might be the difference between someone taking their life or not. That might be the difference between someone falling in depression or not. It's just knowing that I count on my daughter. I count on my cousin, on my brother. I know that we're going to have a beautiful, in-depth conversation tomorrow. Because it's a routine. It's a plan that we've established. So never underestimate that. More recommendations. Make sure that they comply with their medical treatments. Don't ignore comments about suicide. That can never be taken lightly. Immediately tell a therapist or a doctor about these comments. There should be protocols in place in whichever agency or institution or organization that you work in. These need to be abided. And to remind them that with time and treatment, their mood will improve. Whatever they're feeling is not permanent. So, what can we include in a care plan for the elderly facing the COVID-19 pandemic? Summary of affections, kind of keep a close monitor on what are the presenting symptoms or emotions that are prevalent and kind of track them. A plan for medications. You want to know who the healthcare providers are, who, what, when, where, how can you contact them, when and how. Same for emergency contacts for more severe cases or accidents, and advanced guidelines, right? And this can be a very uncomfortable topic to address, but it is obviously in their best interest, and it's something that, in most cases, right, it's something that they would want to make sure is clear, and so it's important to cover that and break that ice and make sure that's all squared. Obviously, the main measures that are in place for prevention, we're talking about distancing within facilities, use of personal protective equipment, control of information sources, cleaning and disinfection, movement, and transportation restriction. Just all things that can add to the emotional distress of this population. So, considering this scenario, if everything that I've offered up until this moment maybe seems insufficient, or that there's additional help or aid that is required, it's important to always have these hotlines accessible. I'm sure most of you are acquainted with the ones here. These are the local psychosocial support hotlines. So if something, if there is risk of harm to self or others, be it through any form of violence or any risk of suicidal activity or self-harm or damage to property. That is when we need to take action. And unless there is another protocol in place for your agency, we need to use these lines that are on your screen right now. So, if you hadn't used them or didn't have them somewhere stored in your phone or elsewhere, definitely encourage you to maybe take a screenshot or write them down to make sure that you always have these hotlines available. So that is the presentation for today, and we have now maybe 15 to 20 minutes to address any of the questions that might have arisen during this presentation. So let's take a moment to hear what you all have to say.
Thanks so much for all that great information.
Yeah, no problem. It's there's a lot more we could go into, but to make sure that we covered the basics and that we could attend the different questions, any concerns that folks online today might have.
Okay, well, we definitely have some questions for you. Are there any fine lines, it says NCD, differences between seniors and regular adults, as well as the varying treatments for seniors versus regular adults?
Talking about the difference between NCD in folks older than 60?
I guess they're differentiating between seniors and regular adults.
Yeah, so typically when we talk about neurocognitive disorders, we're talking about disorders that are onset by the aging process. So it's the aging itself which produces them, and so they appear basically after 60 years of age. That is my understanding, and so folks that are non-seniors, they may be classified differently. It kind of depends on the criteria, but neurocognitive disorders refers to those that are kind of onset by the aging process itself and appear later in life.
Okay. Let's see what else we have. So what is the best way to handle a depressed person during lockdown, living alone, make them wear protection? How do we make it easier for them?
Routine is always the key. To when we have a familiar reality, it's always more manageable to have and to maybe play with what is their current routine, what are their current habits, and how can we incorporate these additions in a way that might even seem seamless, as far as washing hands, cleaning the shoes once you come into the house, washing of the mask, etc. All these different practices that need to be done continually. How can we incorporate them into a pre-existing routine, and almost like maybe even almost camouflaging them? Like if someone needs to take a pill, they really don't want to take the pill, is there a way to pulverize it and include it in their morning orange juice where it's almost undetectable? Kind of that mentality of how can we kind of blend it into whatever routine that they already have in place. That's something that I've always seen seems to work.
Okay. John, can depression bring on or trigger an NCD? For example, the death of a spouse brings on symptoms of both depression but also dementia?
I'm looking here at the slide. You're saying could a neurocognitive disorder be onset by depression?
Could it be a trigger? No.
A trigger?
Could depression bring on or trigger an NCD? So in other words, if somebody's spouse dies, that brings on symptoms of depression, but could it also bring on symptoms of dementia?
You know, I'm not 100% clear. I wouldn't dare. I apologize. I wouldn't dare to respond that. That would definitely fall into the category of pseudo dementia. And I wouldn't dare. I'm not sure exactly what is the distinction between a pseudo dementia and an actual neurocognitive disorder that was brought on by an original depression. And it is kind of that tough gray area because there are many symptoms that both conditions or both realms share. Yeah, I'm not entirely sure about that.
Okay, that's fine. We'll move on. What initial steps should the person or family member take to address the depression, especially during quarantining?
Yeah, that outreach needs to be a priority. To reach out, to establish contact, and when we have that initial contact with them, as I was referring to earlier, to have that open, empathic approach, right? We're there to guide and coach them, and there's some things that we need to know. And we might need to be directive in even asking these questions, especially what medications are you taking, how have your habits been, sleeping and eating, because all this helps us understand what's happening. But as far as those soft skills and the emotional support they need in that moment, before trying to work with changing, patterns of thoughts or beliefs or, any kind of content in their cognition that might be bringing on this depression, we need to have a very open, empathic, and validating presence with them, and just have open ears, really be willing to listen to them, to hear them out, to let them express, whatever it is that they're feeling, and to overall, validate them and help them feel that they're not withstanding it alone, that they can share this weight with somebody else. And, these are the kind of skills that are taught in courses such as psychological first aid. And it's that kind of tact and bedside manner that any healthcare provider, anyone working in a hospital from the front desk to the doctor, we should always have that tact and sensibility to have an empathic encounter. That I would say that is the most important thing, right? To help them feel that they're not alone and they have space to vent with somebody. And then from there, you connect, and then from there you can go into the more corrective action.
Okay, thank you.
Yeah.
Is there an identifiable tipping point at which intervention becomes critical to address the psychological and emotional distress?
Yes, definitely. It's similar to the distinction between a minor and a major neurocognitive disorder. It's the same distinction between a lot of mental illnesses between normal functioning and abnormal or pathological functioning is the following factor. Does it impede my normal functioning in my day-to-day life? That is the biggest red flag. If they are no longer sleeping the way they usually sleep, if they are no longer eating the way they normally eat, if they're no longer able to carry out their daily task or their work or their something that they do every day and that they need to carry out. We're talking about essential activities that they can no longer carry out effectively or independently. Though any kind of interruption of their normal functioning, that is a big. I know that sounds very vague, but that is the main criteria that we need to be looking out for. Yeah.
Okay. Given that seniors tend to be more set or stubborn in their ways and their regular routines, do you have any suggestions on how to help seniors change and adapt accordingly?
Yeah, that's definitely a tough one. In my experience, I was taking care of my father for 6 months, and I've heard of other accounts that are similar. it's kind of like almost thinking, what would you do with a child? How would you work with a stubborn child? How would you make something more appealing for them? And sometimes it's even through humor and games, and that's, that can be a great avenue. And maybe, my dad and I would play a card game, and we love playing that game, and that's a way for us to connect. And we'd play in the hospital, and there's some exercises that he needs to do with his hand to really strengthen his muscles, and it was really uncomfortable for him, and he didn't want to do it. And and there'd be like a little bit of a reward system, like, Dad, like I really want to play cards with you, but we can't play until after you do your exercises. Everyone can find different ways to establish that kind of reward system, or games as an incentive to do those uncomfortable things. That's one thing that occurs to me that's worked.
Okay. Don, do you know, is there an organized effort to develop person-centered planning to support seniors who are without family and friends close by?
You know what? I'm sorry. I'm not aware. You're speaking about like a plan to structure that. You're talking about like a service that helps establish that plan between.
Yeah, I guess
family.
I guess whether or not you've heard of anybody, any organizations, making an effort to kind of develop a plan that could be shared across organizations.
Yeah, here in Puerto Rico, I know of one that does that kind of work. It's not very common, but I wouldn't know how to respond to how that works in New York or other states, stateside U.S. Yeah, I owe you that one.
Okay. Are there nonprofits?
But that's definitely something that is ideal, and that I think locally, we need to look, do our research and see who is providing that, because that is essential. Just like when we're attending our students in a school, you're always going to have the team of the parent, the teacher, and the student. How do we involve all the different parts and coordinate efforts and make plans? Definitely need to have that same approach with elderly. So
one of our listeners suggested that she thought that New York State Department of Health had some information on person-centered planning, if anyone is interested.
Great. Yeah, that would make sense. I mean, that's the first place to check. Our state agencies, Department of Health, they should offer those kinds of coordination services.
Okay. Do you know, are there nonprofits that coordinate opportunities for volunteers to have, let's say, Zoom conversations with lonely seniors in group homes or otherwise? And if so, which ones?
Yeah, see, again, I'm wondering if other people in this webinar, know of these different agencies and services and maybe recommend in the chat box. But I'm a little estranged to how things are operating in different states and on the federal level, and I apologize.
Well, you only speak to what you know. So if there's a program like this in Puerto Rico, we do have listeners on the webinar today that are from Puerto Rico, so certainly speak to those. I was going to add that recently we had an opportunity to speak with a group out on Long Island called, I believe it was Operation Independence. But they have a program in their county whereby they make phone calls to seniors. Like, they really are working very hard to allow seniors to age in place. So in order to do that, they're providing services to include transportation or food shopping, but also just friendly phone calls from other people in the group. So, and I know that they modeled their nonprofit off of another. So I'm sure that there are multiple groups out there that are similar. It just might take a little digging.
Okay.
So next
Okay.
question, how do you get help for nursing home residents that express PTSD-type behaviors after surviving COVID-19 and witnessing more than a dozen of their friends, including best friends and roommates, die from COVID-19 in less than 60 days?
Wow. So the question is how to find aid for those suffering that form of PTSD?
Yeah, how do you get help for these individuals in nursing homes that are suffering from this?
Well, this obviously depends on what are the clinical services available in that nursing home. That's obviously the first place to look, and depends on, how they operate their clinical team, how they divide their clinicians per residents. If that seems insufficient or not, the help isn't arriving or that aid isn't arriving, then definitely we need to turn to those hotlines that we offered, right? Of course, if your family knows of, or the family members of that person know of a family psychologist, a psychologist that they'd like to recommend, you can make arrangements for that. But if not, that is why those lines that we put on the screen earlier exist, right? It's that hotline for those kinds of drastic scenarios where we don't have an obvious resource available. So first, check in the nursing home, and unless that family doesn't have another resource available, then we need to work with the government and find that help.
Okay.
Yeah,
You have a question?
that's a very saddening reality, right? We have these folks who are losing their whole social group. It's devastating. So yeah, that's a very important question.
Yeah, it actually, it reminds me of a personal story. So my grandmother lived to 103, but I always remember her saying, like, I don't want to be this old. My friends are all dead. My siblings are all dead. My cousins are now all dead. Like, who wants to be the last one? And
yeah,
I'm sure that there are other situations. COVID just maybe put a spotlight on it, or maybe condensed it into a shorter time frame. But nobody wants to be the last one standing, really.
No, no, they don't. No one does, and that's why I want to emphasize how important it is for these folks to feel usefulness and purpose in their life. And that was one of the points that we covered in the presentation, is to help them feel like they have utility, that they have a purpose. And it can be, as simple as, there's a granddaughter who loves the pieces of clothing that her grandmother knits for her, or, it can be, almost anything, but that they have a function to fill, and a role to fill in this life that does not make them indispensable. And when you lose your social support group, if you don't have that lifeline, you become much more vulnerable to falling into hopelessness and to lack of purpose, which are enormous red flags, which, So just wanted to emphasize that point.
Yeah, and it can be the littlest things. So, again, I'll add one more personal touch, but, my grandmother really stopped cooking, towards the end or whatever. But the one thing that she still did, and we even videotaped her doing it so that we can now do it, was she still made homemade pizza. She didn't clean, she didn't cook, she didn't shop, but she still made homemade pizza, and, everyone loved it. Family and extended family, everyone called it Grandma's Pizza, So, all right. So enough about Debbie's personal life. We have a question from someone who is a non-clinical care manager. at a local hospital, and she said that she's no longer able to see their patients in person, and was wondering if maybe you had any thoughts on what else she can do telephonically, via telephone. What else could she do? Do you have any suggestions?
I'm sorry, could you repeat? You said what could she do via phone with who? I'm sorry.
So she has patients.
Uh-huh.
She's a non-clinical care manager at a local hospital, and they're not allowed
Yeah.
to see their patients in person. So
Yeah.
what else can they do telephonically?
Well, this is, if it includes video conference, then a lot of options open up. Virtual conferences as in Zoom or Microsoft Teams, where you can have different presentations, or you can put up videos. You can have multiple people seeing each other's faces at once. You can do all types of activities together. It can range, from like fun activities and games to like social, to emotional support groups, to psychoeducational talks. Basically how to promote a sense of community, which is, one of the biggest sacrifices of this pandemic is that we've lost a lot of that sense of congregation and community. So if what she's referring to includes Zoom or Teams, I would really maximize the potential of those platforms to kind of build that sense of community and to offer support in a group manner. That's the first thing that I would recommend. But obviously, maintain the one-on-one non-clinical engagement and support through the phone is great. And as a psychologist, I always think that the more that we can get the non-verbal language included, the better, right? Because 70% of human communication is non-verbal. So we need to feel each other. We need to see each other's eyes. We need to see the gestures in their face, their body posture. All this is very crucial information that helps, satiate that need for human connection. So I think it's important to use video conference as much as possible. And if you can get more people in there and rebuild a sense of community, then even better.
Great. What responses should be provided to seniors who have anxiety from shopping for groceries, et cetera, and having to wipe everything down? I know a lot of folks are worried about going to the supermarket.
Yeah, I mean, and that is a real risk. I wouldn't downplay the reality of that risk. But I would try to guide and coach them in a scaffolded process, using a little bit of what's used to manage phobias in psychotherapy, known as systematic desensitization, where when you're exposed to a triggering stimulus, right, let's say in this case it's actually, leaving the home or entering the supermarket, in those moments there's some relaxation techniques that you can put in practice that if you do them enough times, you gradually teach your body to stop responding the way it used to and to actually respond with more of a relaxation response to the same stimuli. And this is actually something that's used to diminish phobias. So what does this look like? This might sound a little technical, but it's as simple as taking baby steps, right? We, maybe first we walk to the closest pharmacy together and we buy one article and come home. And in that process, maybe they felt a lot of stress and fear, and in those moments we took advantage and we did a muscular tension release exercise or a breathing exercise together, and then we come back home. Maybe the next day we spend a little bit more time in the supermarket. Maybe we get 5 different items and come home, do the exercises. So there's kind of a scaffolded coaching that could be used. That's actually what I would do, and that's something that we've offered in another webinar that we offer to deal with basically cabin syndrome. In Spanish, we refer to it as síndrome de la cabaña, and it's that fear of leaving the home, which is only normal which is, only normal to feel, but we want to make sure that it doesn't paralyze us either.
Very true. Have you found...
life does need to go on, and we need to get food from the groceries, and we need to adapt.
Yes, and there are certain things you can do. I mean, like having your groceries delivered. My feelings are that I'm not going to stop living my life, right, or live in fear. And I know that older Americans are, at a little bit of a disadvantage, but at some point, unfortunately, something, there's one thing certain, right? We will all be born and we will all die. So
That's right.
What the circumstances are that surround that is up to us.
Yeah, it's just, we can't stop living. We do risk management. We minimize risk and we minimize, but we can't do it at the expense of just kind of halting our life. That's a challenge that we face. Obviously, it's easier for me to say that as a 28-year-old young man. So, it's also always important in these processes to validate what the elderly are feeling. The threat is real. But we can help kind of coach to just step out a little bit more if need be, to just carry out basic life functions.
Exactly. Have you found that a strong faith or spirituality support in a senior's life can bring on a healthier response to this situation?
Absolutely. And not, that doesn't mean that it's a necessary condition, but as Carl Rogers would say, it's sufficient. It's definitely a game changer for many folks that I've had contact with, including my father in his final stages. It's a source of strength. It's a source of purpose. It gives meaning to the suffering that's being endured. And many times, if we can't give meaning, or if there's no purpose in the hardship that I'm having to face, it just becomes much more difficult to find the strength to overcome it. But if and spirituality can many times offer that meaning or that purpose that kind of goes beyond and makes sense of all this that I'm living. So in that sense, and that doesn't have to be, a single form of religion or a religion, and there are many things that can give that purpose that goes beyond me. Maybe my greatest faith is in my family, and I'm going to stick it out and give every last ounce of strength, for my family or for my, I think it's a matter of ulterior purpose and meaning that helps us navigate rough times. Definitely.
Okay. Are there services to assist in coping with this pandemic, such as those previously mentioned for the visual, hearing, and verbally impaired?
For those who are who have impairments such as blindness or
such as sight, visual, hearing, and verbal.
Yeah. Well, I mean, every elderly home, every hospital should, they should definitely have in place accommodations for those diverse populations, and if not, that's a serious concern. So I would look to see what services are available. If they're not available, to know how to defend the need for those resources, right? To know the rights and the kind of the policies of that institution, and demand that be made available for those folks. So yeah, that's kind of more of a case by case scenario. We gotta see what's available in that center.
Okay. Are you aware of any financial aids that might be available for seniors living alone to use Lifeline call out?
Yeah, trying to think. I don't have the name in mind, but again, these are social services that that should be facilitated by state health agencies and the Department of, in Puerto Rico we call it Departamento de la Familia, the family department. Yeah, I'm not sure what the other state regulations are, but that is definitely a legal aspect that the state does need to offer aid to those who are alone at that age and as vulnerable as they are.
All right, we just have one or two more questions, John.
Yeah.
Any reflection on the availability of vaccines in the foreseeable future having an impact on mental health of elderly at this moment?
Yeah, I mean, I think one of the biggest flags, that I see is that, as we've seen with the rise of this information age and social media and fake news, we can see a proliferation of a lot of rumors, maybe falsehoods spreading through the internet that can create a lot of fear, that can, give rise to dread and anxiety and fear about the vaccines. So I think that is one of the major risks is the kind of cascading amount of information and rumors and a lot of times fake news. I think it's really important to really stick to valid sources of information regarding public health, and to really stick to those and just make sound decisions based on that. Sources such as CDC and SAMHSA, the Department of the state departments of health and the World Organization of Health. I think those are the three main sources, and try to avoid just the overload of information from fake news and social media, which can provoke a lot of emotions that we don't need to be feeling.
Okay. And just one last question, but for our listeners, if you wouldn't mind, there is a 3-question poll on your screen. If you wouldn't mind just answering those 3 questions, it really does help us determine future programming. Last question for you, John, is how can you use some of the techniques that you talked about in rural communities where maybe you can't get to the store every day to kind of desensitize?
Yeah, that's a good question. So when you say you can't get to the store, you're saying like, it's like quite a trip to get to the store. Is that what you're saying?
Well, that's what I'm guessing the listener is saying, yeah.
Yeah.
Yeah. Actually, she replied, yes, that's exactly what you say.
Yeah. Yeah, so, it takes quite a big, leap of faith or, commitment to, like, go do this excursion, to go, buy my articles. I would say, if it's possible, and this might also be another luxury, but, like, if it's possible to go with somebody, just, to share the experience with somebody, to have someone to support you, not only with the task, but just for that emotional company, be able to just kind of vent and like go through the process with somebody, I think will definitely lessen the emotional burden. I would talk to any locals, in their neighborhood or in their, wherever they're living, any friends that they could make contact with and just kind of get a briefing on like, hey, what was your experience? Did you go there? What was it like? What did you come up against? Do you think I should take this and that? How long did it take? And to just have, to prepare yourself and really make a game plan based on information, like knowing what to expect and to make a solid plan, because all of that affords us a sense of control. And what we fear the most is uncertainty and lack of control in life, and if we can have a sense of like, okay, wait, I know what to expect, it's a big journey that they're going to make, given the risk. And if, if they need to, who knows if it takes, an hour to get to this place and all the different social situations that they might have to encounter just on the way to the supermarket, good to have a good idea of what to expect, what the main risks are, what route I can take, what protective measures, what time of day is best, and just have that sense of control of like, okay, I know what I'm getting into, and I know what I'm going to do to protect myself. Let's go. I think that is the best that one can do, unless someone can go for you, obviously. But you know, if it comes down to needing to take care of your own needs that way, then that's what I would advise. And especially if you can go with somebody else, that would be ideal.
Well, John, I have to say, and I don't know if you've been reading the chat box, but that was an excellent presentation.
Thank you so much.
There's nobody that walked away that did not get something out of today's presentation. I really appreciate you taking the time to spend with us today. Everything, we really do appreciate it. And I want to thank our participants. I think I saw over 300 or 350 participants today. Thank you so much for joining us. We have a lot of great webinars coming up for the rest of the month. I'm looking at my list right now. We have 10 more webinars between now and December 17th. There, if you go to the links on your screen, you can see all our upcoming webinars, which include in Spanish, supporting emotional health for K through 12 students, the emergency financial aid kit. We will have the SBA here talking about disaster preparedness for small businesses. We have a great FEMA speaker talking about communications. We are going to spend 2 hours just helping individuals develop the right types of introductions. The CDC will be here to talk about influenza vaccination week and what that means. We have great presentations coming up on dialysis and disasters, assistance animals and pets, part 1 and 2, influenza vaccine in Spanish, and dialysis in Spanish. So please join us. Today's webinar, like all our previous webinars, has been recorded. It is on the FEMA.gov site. You can find it by clicking the recordings. You got to give us a little bit of time. It usually takes us about 2 weeks or so to get them posted. I am very excited to say that we got approval last week to start posting our webinars on YouTube. So we are working on getting our webinars from this past year. And come December 31st, that will total 110 webinars where we've had subject matter experts like John Ruan talking about very important subjects to our stakeholders. So thank you, everyone, for joining us. Have a beautiful, beautiful day. You're free to drop.